I'd like to introduce our Dr. Kaplan, who will serve as our moderator for today's event. Dr. Kaplan earned his medical degree at the University of Texas Southwestern, followed by internal medicine training at Duke University. His expertise extends to cardiology and electrophysiology gained through training at Emory University. Based in Phoenix metropolitan area, he currently serves as the Director of Electrophysiology at Phoenix Heart, Vein, and Vascular. Dr. Kaplan's extensive involvement in clinical research spans over 75 trials, with roles as both clinical and principal investigator. He currently serves on the Verdict's Medical Advisory Board. Dr. Kaplan, the mic and the stage are yours.
Thank you, Holly. It's wonderful to be here and wonderful to have such a large audience joining us this evening. My journey with the Guardian has been long. I was a clinical investigator for the ALERTS trial and have been able to follow it from a research standpoint through its commercial development and getting it out to my patients. And so it gives me great pleasure to join you this evening. What I'd like to do is present the results of a study that I recently presented at the TCT conference in San Francisco entitled Medication Adjustments Associated with Implantation of a Cardiac Alerting Device, the ALERTS trial. So as you've already heard, the Guardian is the world's first and only implantable system designed to detect acute ischemic events related to coronary artery occlusion. Alarms prompt patients to seek medical attention. ALERTS was the pivotal trial evaluating the efficacy and safety of the Guardian system. The primary endpoint was positive for improved recognition of acute ischemic events compared to symptoms alone, and for reduction in symptom to hospitalization presentation time. As part of the study, data on the use and adjustment of medications was collected. This was felt to be important because ACS patients remain at high risk for adverse outcomes after initial treatment. The high-risk ACS patients all had to have experienced an ACS event within 6 months or had undergone or had planned to undergo coronary bypass surgery within the next 6 months. The major exclusions were presence of a clinically significant arrhythmia, which could either reduce accuracy of the device to detect ST segment changes or could lead to the need for an implantable CRM device. Randomization took place at the first post-implant visit. All patients who were enrolled in the trial did receive a device implant, which is very similar to a pacemaker insertion. Most of these were done as outpatients. The follow-ups were scheduled according to physician preference as well as per protocol. Additional visits could be unscheduled, related to either changes in symptoms or for device alarms. At 6 months in the study, there was a crossover with alarms turned on for the control group. The active alarm group continued to have alarms on, and both groups were followed for the remainder of the trial. As you can see, for the emergency alarm, the patient was told to go to the ER for evaluation, and then for the C doctor alerts, they were told to contact their physician and to come into the office to have the device interrogated. Patient notifications can be broadly broken down as to whether they were ischemia related or rate and rhythm related. For ischemia, the emergency alarm would constitute an ST segment shift in the absence of a change in heart rate, or if there was ST segment change associated with persistently elevated heart rate. On the other hand, for the C doctor, there was a negative ST segment shift, otherwise known as a recovery event, in which there was ST segment changes just after a recent interval of higher heart rate, or if there were ST shifts associated with elevation in heart rate lasting for more than 10 minutes, constituting demand ischemia. This is essentially the equivalent of a stress test. In terms of the heart rate and rhythms, alarms could occur for either high or low heart rates, as you can see here for the specific indications. And they also could occur in instances of an irregular heart rate. This is an example of some of the data that's available. Device interrogation will show the reason for the alert, as you can see in the lower left corner, with this example occurring because of a high heart rate. Additionally, there are pictures of the electrograms that are captured by the device at baseline as well as hourly, and then within minutes before and during the event. Additionally, as you can see, there's 6 months of heart rate histograms that are available for review in the lower right corner there of the slide on the left. The primary endpoints were assessed for 907 subjects who were broadly broken out, and data for medication usage adjustment was also collected as mentioned previously. Medications were classified into 4 specific groups. The first were the class 1 and 3 antiarrhythmic medications. Group 2 were class 0, 2, and 4 antiarrhythmics. Group 3 constituted antiplatelet and anticoagulant drugs. And then group 4 were non-cardiac related as well as hypertension medications. The potential reasons for adjustment could be through a standard of care visit, through visits due to symptoms, or for the scheduled visits that occurred at 1 month, 3 months, 6 months, and then every 6 months thereafter, which would constitute a visit along with review of the intracardiac data. Patients could also have their data evaluated due to C-doctor alarms or emergency alarms. The ALERT study did not survey doctors on the rationale for medication titration, but the only differences between the 2 cohorts would be the availability of intracardiac data and then the various C-doctor and emergency alerts. This is a breakdown of the types of alerts that were occurring for the C-doctor alert type. The majority of the alerts were related to abnormal heart rhythms across the groups in the alarms on, crossover, and then continued alarms on, with a fairly even breakdown of whether they had a high heart rate or an irregular heart rate. There was also a smaller but still significant number of non-acute ischemic events documented. All of these alerts could lead to medication titration. These are the results of the study. The number of patients with medication titration was 220% higher in the alarms on group compared to alarms off for group 2 medications, as seen in the upper left portion of the slide. This was highly statistically significant by chi-square analysis. There were no significant differences for other medication groups. The total number of medication titrations seen in the lower left was 162% higher in the same group with alarms on. There was an equal number of new scripts as there were for dosage adjustments in previously prescribed medications. An increase was also observed for the crossover group of 25% compared to the existing alarms on group, again, strictly for group 2 medications. This was a positive trend, but did not reach statistical significance. You can see there was also a catch-up. This was believed to be a catch-up for the group that now had data available for the clinicians. This is an example of a detection related to high and irregular heart rate, in which you can see that the patient has atrial fibrillation. The benefits of an intracardiac electrogram are that you can clearly see both atrial activity as well as ventricular signals, and we can get a handle on the heart rate control with these events. These are 2 more examples on the left, being somebody who had a high burden of ventricular ectopy with ventricular trigeminy documented. And then on the right, an example of supraventricular tachycardia. Both of these could lead to medication adjustments and/or electrophysiologic intervention. The conclusions that arose from this study were, number 1, that high-risk ACS patients remain at risk for recurrent ischemic and dysrhythmic events related to their underlying substrate as well as progressive disease. The presence of an ischemia monitoring device with additional heart rate and rhythm diagnostics led to significant differences in the use of group 2 medications, that is, beta blockers, calcium channel blockers, and ivermectin, reflecting enhanced patient management. This may have contributed to positive outcomes from the trial. Likewise, it may prove to enhance long-term outcomes in these high-risk patients. This will be evaluated in future research.